Thank you very much, Harold. It's a pleasure to be back here. We appreciate all of you all taking time from your busy schedules to meet with us today. And vertigo is something that's near and dear to my heart. Thankfully, I've never had a vertigo spell, but I feel like I have a good understanding of vertigo because it is one of those things that's one of the most frightening things that can happen to a person. When the world is spinning, all these questions start going in your mind. Do I have a tumor? Am I having a stroke? What's happening to me? And it's incredibly frightening. And so you not only get this very visceral, emotional response, but oftentimes there's the nausea and sometimes even vomiting that goes with that. And it's just an incredibly frightening experience. So we're here to kind of try to make sense of it, to try to help give you an understanding about what vertigo is, how it happens, and what we can do to treat some of the more common forms of vertigo. So I'm very fortunate at the Jacksonville Hearing and Balance Institute to have a team, and several members of our team are here with us today, and we'll be introducing them as we go along. And there are even a few team members out kind of scattered amongst you there, so there'll be people to answer your questions towards the end of the presentation today. Thankfully, we've been able to be present now for 22 years here in Jacksonville. It seems like it's just gone by in a flash, and I've had a chance to help a lot of people here. So I'm very thankful for the people of Jacksonville and for how they've welcomed us, and just thankful that we've been able to offer subspecialty to help to so many people here. We take care of vertigo problems, but not only vertigo problems, but also problems related to hearing, problems related to ringing in the ears. We have 6 audiologists that work in our practice that fit people with hearing aids and take care of a variety of hearing problems, including cochlear implants and bone conduction type hearing aids, basically covering people from the cradle to the grave with regard to hearing. So we're thankful to be able to offer that type of care. We also take care of some of the more common things, earwax, very basic things, and certain tumors and things of that nature that occur deep within the ear that can definitely significantly affect quality of life. And we'll be discussing some of those as the presentation moves forward. So dizziness and vertigo are some of the most common symptoms that a person can experience. It's estimated that approximately 20 to 25% of people at some point in their life will seek out medical care because of a problem with vertigo or dizziness. So that's an incredibly common problem. Estimates are that about 3.9 million emergency room visits per year are related to vertigo or dizziness issues. So it's extremely common. Those of you that have not experienced vertigo or dizziness probably have a family member or a friend who has. Vertigo and dizziness can be caused by a number of different problems. So our focus is on the inner ear, but the inner ear is not the only area that can cause problems with vertigo. Vertigo problems can be caused by cardiovascular problems. Inadequate blood supply to the brain can cause a lightheadedness or dizziness or even temporary loss of consciousness. A neurological disease such as a seizure or a restriction in blood flow in the blood supply to the brain can also cause a problem with vertigo or dizziness. And even a number of other types of problems that are related to the central nervous system can cause vertigo or dizziness. So we'll touch on some of those things, and unfortunately we don't have time to do an exhaustive coverage of those things, but we'll cover some of the more common ones. And one of the things that people come in, and they come in with this question of what happens to people like me? You know, I've had this vertigo spell, I'm feeling off balance, what happens to people? And part of our job is to put it all together and to give them answers as to what happens. And I'm here to tell you that one of the exciting things that we have the opportunity to do is to provide hope to people that have had vertigo, because there are treatments, and it can be treated, it can be helped. And one of the messages that I hope all of you will walk away with today is that vertigo and dizziness are treatable problems. There's a common misconception out there that you can't treat vertigo, you can't treat dizziness problems, and that's just inaccurate. So we want you to take that away. So I'm going to ask one of my physician assistants, Donna Smith, to join me on the stage here. And Donna is a physician assistant par excellence. Donna has worked at the Mayo Clinic for a number of years. She's also taught here at Nova Southeastern's campus, where they teach physical therapy students. So she has a wealth of experience, and she's worked with vertigo patients over I don't want to date her. She's been working for a number of years. We'll just leave it that way. So, Donna, I'll give the stage to you. Thank you very much.
Thank you, Dr. Green. 35 years, so it's been a while. But thank you. Welcome. I'm glad everybody could come out and have lunch with us today. Can you hear me okay? All right. So first of all, does this come out? No. What is vertigo? That's something that everybody asks. Is that a disease? What is vertigo? Vertigo is actually a symptom. It's a name that we give to anything that represents a false sense of motion. Some people feel like they have spinning in their head. Others may feel like they're rocking, like on a boat. Others may see the room actually spinning around them. So that's vertigo. That's a symptom. And I want to share a story with you all. It's been in the news recently, so it's perfectly okay to talk about this. This is Kelley Stafford. She's pictured here with her husband, Matthew Stafford. Some of you may know him. Or know of him. He's the starting quarterback for the Detroit Lions. He has a really good job. About a year ago, well, first of all, Kelley was a cheerleader, so she's got pretty good balance. She was a cheerleader at University of Georgia, where Matthew also played a little bit of football. And about a year ago, she noticed that her balance just wasn't as good as it used to be. She actually attributed that to age. And my goodness, she's, I think, late 20s. But she thought, well, I'm just getting older, so we'll give her that. But she has 3 small children. They have twin little girls and a little baby boy. And she wanted to teach them how to do somersaults and cartwheels and how to spin like a ballerina. And she realized she was off balance when she tried to do that. So she just passed it off. So this was about a year that she was feeling that sort of thing. In January of this year, she had a terrible episode of vertigo, her first episode of true spinning vertigo. She was terrified. She was miserable. Matthew whisked her away immediately to the emergency room, where they didn't do a lot. It sounds like they did some vital signs, and those were stable. So then they checked some blood work. It was fine. And they said, well, you probably had a little episode of vertigo. Just go on home. And she continued to have episodes of vertigo. The last straw, when she was holding Hunter, their baby, she had a very bad episode of vertigo. The team physician for Matthew, thankfully, the team physician for the Detroit Lions said, you need an MRI scan of your brain. This is a picture of the MRI scan of her brain, which she put the arrow, I did not. She put the arrow, and it points right to what's called an acoustic neuroma, also known sometimes as a vestibular schwannoma. Dr. Green is going to talk a little bit more about this, but this is one of many conditions that we treat at Jacksonville Hearing and Balance Institute. Update on Kelley. She had her surgery, I think it was right before Easter, a couple of months ago. She updated her status about 2 days ago, and she's doing beautifully. She's recovering very well. So it's a happy ending. This could have grown and taken her life, but intervention helped. Moving on a little bit, I want to tell you what it's like to come see us. So it's a very pleasant experience. The first 30 minutes or so, you'll be spending time with one of our doctors of audiology, like Dr. Kelley. They're going to do an audiogram. That's a hearing test. It's a very thorough, very complete hearing test. And you might ask, well, why in the world do I need a hearing test? Honestly, can we skip that? My hearing is fine. The reason we do that is the hearing and balance nerve is actually the same nerve, the 8th cranial nerve. So sometimes, by looking at the hearing test, we can get an idea of what may or may not be going on that could be causing or contributing to your vertigo or dizziness imbalance. So the hearing test is a critical part of the assessment. Dr. Kelley's going to talk a little bit more about that later. Once you're back in the exam room, which will be with myself, Judith Nelson, who's here today, is another excellent PA with us, and then, or Dr. Green, of course. One of the three of us is going to talk with you in the exam room. We're going to ask you about your dizziness, and something I might say to one of my patients is, could you please explain to me what it feels like when you're dizzy without using the word dizzy? I want to know if you're lightheaded. I want to know if the room is spinning, or do you perceive that you're spinning? Are you off balance? Do you feel like you're on the boat? I have a lot of questions, so I always thank them for their patience with those questions. I'm also going to want to know what seems to bring it on. Have you noticed a trigger? Is it when you roll over in bed? Is it when you've been out in the garden working on a hot day and you stand up too fast? Is it not positional at all? Is it when you're sitting at a computer? Those things are more clues to the puzzle. Another part of the questions we ask is, how long does it last? Is it seconds, minutes, hours, or days? All of those detailed questions are critical in us sorting out, as Dr. Green mentioned, the puzzle of why am I having vertigo, dizziness, imbalance. Next, we move on to the exam portion. Nothing scary, nothing painful. We'll be looking in your ears, your nose, your throat. Something that you may not get at your primary care office is we will often gently, slowly lay you back on the exam table with your head in a very specific position, and we'll be staring at your eyes. Why are we staring at your eyes? This is something wrong with my ears. The eyes are the window to the inner ears. Thank goodness, the way we're connected, beautifully made. We can look into the eyes and see what's called nystagmus sometimes, and that also gives us a clue, a huge clue, as to what can be going on in the inner ear. I want to teach you a little, happy faces when you come in. This is who you'll be greeted by at the front desk. So I want to teach you a little bit about the anatomy and physiology of the ear. So when Dr. Kelley talks about the testing and Dr. Green talks about some of the diagnoses we see most commonly, you'll have a better understanding. This is the ear's broken down here into three sections. Sort of the orange or fleshy color is the outer ear. Then the middle ear is in pink, and the inner ear is in blue. The outer ear is where we're going to capture those sound waves. You can see where it looks a little bit like a funnel almost. So the sound waves are captured there, then they're going to travel down the ear canal and vibrate the eardrum. The eardrum is right there. Then we go into the pink area, the middle ear. The middle ear is going to allow that vibration to be carried on through the malleus, the incus, and the stapes. Those are the little bones in the middle ear. You may remember them as hammer, anvil, stirrup. Then we go on into the inner ear, pictured in blue. That's more where our focus is today. But those sound waves for hearing, they're going to spiral through the cochlea right there. That's the organ of hearing. There's microscopic sensory nerve endings in there called hair cells. They're amazing. The hair cells are going to convert the vibration to an electric signal. But let's focus on our talk today is going to be the inner ear, the blue part. This is an enlargement of that. So again, there's the cochlea here, the organ of hearing. Then this part is for balance. That's the focus of our talk today. The area right here houses what's called the saccule and the utricle. Those areas are responsible for detecting gravity and linear motion. That's also where the crystals live. You all may have heard about the crystals, microscopic calcium carbonate crystals. Does anybody know what calcium carbonate is? Limestone. So we all have rocks in our head, but sometimes they come loose. So that's something that Dr. Green and Dr. Kelley will also be talking about. The other area, there's three semicircular canals. It's a mirror image on both sides. So on each side, right and left, we have what's called a superior, or on this slide they call it the anterior superior semicircular canal. There's a horizontal canal on each side, and there's a posterior canal on each side. Those areas are responsible for detecting angular motion. Then you'll notice the orangish color there. That's the 8th cranial nerve. It's divided into sections I want to tell you a little bit about. The division that's coming out of the cochlea is for hearing, so that's referred to the auditory nerve. That's where those electric signals, after they're converted from a vibration, they zip right through that, and then they land in the brainstem, which is where we process it as sound. The vestibular nerve is pictured above that, and you can see where there are actually two divisions of the vestibular nerve. There's a superior division and an inferior division. Both of those areas gather the signals from all of the semicircular canals, the utricle and the saccule, and they send that to the brain for processing. And at this point, Dr. Kelley is going to come up and explain a little bit about the testing that we do on those areas to help determine why you might be having those symptoms. Okay.
All right, so like Donna mentioned, my name is Dr. Kelley. I am one of the audiologists at JHBI. I am going to go over the 4 different parts of the testing that our patients will typically undergo while we're trying to unravel what is causing their dizziness. So here are the 4 different components. There's the computerized dynamic posturography, the vestibular evoked myogenic potential, rotary chair testing, and then video nystagography. Now, all of those are quite a mouthful. So in the field of audiology, we love our acronyms. Everything will be abbreviated to a more manageable abbreviation there. So the first part is the computerized dynamic posturography, or we shorten that to CDP. All right, so this is what the machine looks like. So there is a balance board, and then the patient will be facing the pictures while standing on that balance board. That balance board is going to be picking up the distribution of the patient's weight. Now, like previously mentioned, the patient will be standing up on the balance board facing the picture. Sometimes that balance board will move, sometimes the picture will move. The patient's job is just to stay as still and upright as possible throughout the entire test. There are several different conditions. These conditions will be done with both eyes open and eyes closed. So what is this contraption testing? So the brain uses 3 overall systems to stay upright. First is going to be the vestibular, or the inner ear system. Second will be the visual, or the eyes. And then third is the somatosensory system. That is the touch sensors on the bottom of our feet, our ankles, knees, legs, and how it knows where our weight is distributed over space. So this machine is able to look at the function of those 3 overall systems and then look at their interaction with our upright posture. And we're able to isolate that function just in case the patient has a global deficit in one area or another. We're able to pick that up with this test. The next test is going to be the vestibular evoked myogenic potential, or we shorten that to VEMP. So with this test, the patient is going to hear a thumping noise in one ear. All the patient needs to do is turn their head and hold, turn their head and hold. The object of this test is to activate the muscle on the side of the neck here. Now, there will be electrodes on various parts of the faces and the neck. Those electrodes are going to be picking up a reflex that is stemming from the inner ear. So what is this test looking at? So Donna previously mentioned that the 8th cranial nerve has 3 different bundles. So the first bundle is tested by that hearing test that we do at the initial visit. The second bundle is tested by the VEMP here. There's also a little organ in the inner ear. It's called the saccule. The saccule is looking at head movements in the vertical plane, and we're able to test how the saccule is functioning here. Third is going to be rotary chair testing. So rotary chair testing has 3 subparts. There is ocular motor testing, SVV, or subjective visual vertical testing, and then lastly is sinusodal harmonic acceleration, or we shorten that to SHAW. So this is what the rotary chair looks like. So either me or one of my colleagues will be at the controls, and then the patient will be sitting in the rotary chair there. And we are tracking the eyes, as you can see on that monitor. So the head, as you can see, is fixed into place. There's a certain angle that we want the head at, so we just don't want the patient to move their head. But the patient is sitting down for the entirety of this test. So what do you do in this rotary chair? Basically, the patient will be sitting in the rotary chair, and then they're asked to perform various tasks. So for the first part, the ocular motor part, there will be a light inside of the chair. That light will move in various directions. All the patient needs to do is follow the light with their eyes without moving their head. The second part, the subjective visual vertical, or SVV, there will be a line in the rotary chair that is tilted to one side or the other. The patient then uses buttons to make that line perfectly straight up and down, just like a flagpole. And then lastly, that harmonic acceleration. All the patient needs to do for that part is actually keep those eyes nice and wide open, staring straight ahead. This is the part where the chair is going to turn, so hence rotary chair. The chair is never tilting though. It's not going to tilt upside down. What it's going to do is turn to one side and stop, turn to the other side and stop. All the while, the patient just needs to keep their eyes nice and wide open, staring straight ahead. So what do these seemingly random tests look at in respect to the vestibular system? So ocular motors, or those different eye movements, that is looking at the function of different parts of the brainstem. So this is the part where we try to piece together whether or not the person's dizziness is caused by central issues, meaning brain issues, versus peripheral issues, meaning something in the ear. The third part, the SVV, or that vertical line test, that is looking at the health of another little tiny organ in the inner ear called the utricle. So the saccule was looking at head movements in the vertical plane. The utricle gives us movements about head movements in the horizontal plane. It's also looking at the health of that third bundle of nerve there. So we have all three bundles covered. Shaw testing is a very important part of our testing. It is looking at both inner ears and how they work as a team together. So here is where we start to piece out, does the person have a unilateral weakness, meaning one-sided, versus a bilateral weakness, meaning both sides. And the last test that we will typically do is called the video nystagography, or again, mouthful, we shorten that to VNG. The VNG has two different portions. There is positional testing, and then there is caloric testing. So the positional testing, again, we are tracking the patient's eye movements. As Donna said, the eyes are the windows to the ears. And we lay the patient back in a couple different positions to see if that triggers any dizziness. For some people, their dizziness is positional, meaning it's triggered by this position versus that position. So we want to see that in office. And lastly, the caloric testing. So caloric testing is when cool water and warm water are put into the patient's ears. This will either inhibit or excite the function of that ear. How it works is the cool and warm water will change the temperature of the ear canal, which in turn changes the temperature of our inner ear fluid. And that response, it's actually a normal response to be dizzy. Now, it's very short-lived dizziness. It's about 40 to 60 seconds of dizziness. As soon as the ear canal returns to its normal body temperature, that feeling will go away. The patient's job is to keep those eyes nice and wide open, staring straight ahead, because we're, again, tracking those eye movements. So what are we looking at with these tests? So Donna briefly mentioned BPPV, or benign paroxysmal positional vertigo, where those little crystals break off and float around where they're not supposed to be. Dr. Green will look more in depth into that, but basically the positional part of the VNG test, we're looking at possible BPPV in any of the 6 canals that we have. And then the caloric testing is very, very important testing because this is ear specific. So again, this is where we can confirm if the patient has a unilateral or one-sided weakness, and then which side is it on, versus a bilateral or two-sided weakness. Now I'm going to hand it off to Dr. Green. He's going to talk more about various conditions, and he'll also talk more about the medical management of those conditions.
Thank you very much. So you can see that I'm very fortunate to have a great team. It's a team sport, just like football or anything else. Having a great team makes my job that much easier. So thank you, Janelle, and thank you, Donna, for your help. I want to talk about some of the different diseases. We've been talking a lot about crystals, so I thought we'd start with crystals here. And in case you ever wondered what your crystals look like in your inner ear, you've got a picture of it. These are the calcium carbonate crystals that are normally present in everyone's inner ear, and they shift in response to movement. So when your car accelerates or your car decelerates, or when you go up or down in an elevator, the crystals are moving, shifting very, very gently, causing either stimulation or inhibition of the nerve endings, depending upon which direction the vehicle is traveling or the elevator is going. So one of the problems, though, that can happen is that the crystals can come loose, for lack of a better word. And when they come loose, they can find their way into the lowermost of the 3 balance canals. And it will typically stimulate that lower balance canal, the posterior semicircular canal, in very significant ways when it happens. It's extremely frightening. It's very short-lived when it happens. And it's triggered by very characteristic positional changes. So when someone rolls over in bed, that would typically stimulate the vertigo that would be caused by positional vertigo and lasting only 30 to 60 seconds. It seems like it's longer, but it's short. Sometimes the vertigo would be triggered by looking up to the ceiling. Some places I've heard it called top shelf vertigo, because when you look at the top shelf at the grocery store or in your home, it will occur. It can also occur when you bend over to pick something up or to tie your shoes, and that's also one of the characteristics. These are some of the things that we try to find out as we're talking with people to really discern what is causing it. And as I mentioned, the otoconia here get into one of the balance canals, and most of the time this will happen for no known reason, for no known cause. And it happens a little bit more commonly in seniors than it does in younger people, but I've seen children with this, so it's not. It can happen literally at almost any age. And many times we'll see it after someone has a closed head injury. Someone falls and hits a hard surface. That is one thing that can cause, we think, the little crystals to come loose from the nerve endings and can lead to the positional vertigo. So that's one of the more common things that we see. The good news is that it's an easily treated problem. The treatment is so simple that for years there was a Dr. Epley who was in Portland, Oregon, and he developed this treatment, and it was so simple that everyone thought he was crazy. They thought he was bananas. That's just too easy. It just works too well. And time has shown that Dr. Epley was exactly right in the way that he was treating this, and that by turning the head a certain way over a certain length of time, you can actually use gravity to pull those little crystals back into the proper part of the inner ear and get rid of the symptoms. So it's a very frightening problem that has a very simple treatment. About half the time, a second treatment would be required, or sometimes even a third treatment. But over 90% of the time, we can get rid of the vertigo symptoms with a very simple treatment. So definitely a treatable form of vertigo, and one that is very, very common. Some of you in the audience, has anyone had positional vertigo in the audience? Great. Yeah. Well, you can attest to how frightening it is when that spinning occurs. So let's shift gears and talk about another common form of vertigo, Meniere's disease. I've just seen a couple of patients even this morning that have Meniere's disease. Again, a very, very frightening form of vertigo. Meniere's disease was originally described by Dr. Prosper Meniere, a French doctor in the 1800s. And he was the person that kind of linked this to the inner ear. And he found that people with Meniere's disease had fluctuation of hearing. They would hear better some days in one ear than the other ear, and that would be better and go up and down. And that we later learned had to do with the inner ear fluid pressures. Also, there would be a pressure sensation that oftentimes would accompany that fluctuation of hearing. And then there would be a fluctuation of tinnitus, or pressure, ringing, roaring in the ear, that would oftentimes accompany the changes in hearing, and that would accompany the symptoms. And then when these symptoms occurred, the patients were at risk. It didn't always happen, but frequently they would have a vertigo spell. The vertigo spell, unlike the positional vertigo, lasts typically for at least 20 minutes, oftentimes longer than 20 minutes, and it's accompanied most commonly by nausea and sometimes vomiting. It's an extremely unpleasant problem, and it tends to happen at the most inopportune times. So you're out in the middle of shopping at Walmart, and all of a sudden you start feeling this pressure in your ear, you know your hearing's going down, and all of a sudden you think, oh my gosh, I'm going to have a vertigo spell, and then pretty soon you're down on your knees or laying down in the aisle there, and I had a pastor recently that had this, and you can imagine if you're getting sick to your stomach and you're out in public somewhere, what do people think is happening to you? Think, well, he's been hitting the bottle or something. So it can be very not just a horrible thing, but terribly emotionally and terribly embarrassing and terribly frightening to the person that it's going to happen again. Well, it happened in Walmart. What's to say it's not going to happen? And so one of the patients I saw this morning said, you know, I just am afraid it's going to happen when I drive a car, so I just haven't driven a car for the last 4 months. So it can be very debilitating in the way that it affects people and in the limitations that it imposes upon them. So what has come to be found a common finding with Meniere's disease, if you were to look into someone's inner ear once they passed away, if you could look in with a microscope into their inner ear, you would be able to see that there's a swelling of the inner ear. The medical word for that is endolymph hydrops or endolymphatic hydrops, and that's basically a swelling or a distension of the endolymphatic spaces. That's one of the types of inner ear fluids. And so this inner ear fluid, endolymph, is present to an excessive degree, and we think that that's what causes the fluctuation, the up and down hearing, the vertigo spells, and the fluctuation of ringing in the ear as well. There are some instances, and we think it's about 10% of the time, where someone has a Meniere's disease and it's related to the body's immune system. Sometimes the body will recognize a part of the inner ear as being something foreign, and the body will develop an inflammatory response. And so frequently we will check for certain types of immune laboratory studies to see if that's the case. It's a little bit more common if it involves both ears. The management is pretty simple, actually, and 8 out of 10 people will respond to medical management. Typically, the management is with a low-salt diet and with a particular pill called a diuretic that causes you to lose some of the sodium when you go to the bathroom. And it does make you go to the bathroom a little bit more, but it works very well. Like I said, 8 out of 10 people respond, and it gets rid of these horrible symptoms. So it's a great treatment. There is another form of treatment. It's a pressure-related device. We did some research with Medtronic, one of the local companies here several years ago. It's called the Meniere device. It's a minimally invasive treatment option that many people do find helpful, and so that's a nice device. And then for people that do not respond to medication and where their lifestyle is significantly impaired, there are surgical options available. And the surgical options work very, very well. Obviously, it's more invasive. It's more of a there's some additional risks in doing an operation, but many times that risk is worth taking if the symptoms are severe. So, quality of life. Meniere's disease, I tell people it's not fatal, but it's a horrible effect on quality of life. There was a study done a few years ago where they looked at quality of life for different diseases. And Meniere's disease and the quality of life with Meniere's disease is comparable to someone that has end-stage cancer. So that's how severe the effect can be. So a lot of times we'll talk with medical colleagues or sometimes with an insurance, a doctor that works for an insurance director, a medical director for an insurance company, and they'll say, well, gosh, why are you going to do surgery on this person? This is just, it's not going to cause any effect, but then we can point to these kinds of things where it really does severely impair quality of life. So we talked about a couple of different inner ear problems, benign positional vertigo, and we talked about Meniere's disease. There are, every time someone gets a vertigo spell, it's not Meniere's disease and it's not benign positional vertigo. People will have sometimes a problem with the inner ear that causes a vertigo spell where the hearing is not affected. And so they might have a severe vertigo spell. Sometimes it will last 24 hours or so. And they get sick to their stomach, and it's a horrible experience, and they're off balance for several days afterwards. They end up in the emergency room. And we'll oftentimes find that when Dr. Kelley or one of our other audiologists tests them, they'll find that there's some damage to one inner ear. But yet the hearing is okay. And that's when someone might have experienced a problem with labyrinthitis or with vestibular neuronitis. A couple of big words. Labyrinthitis means that there's been a problem with the labyrinth, with the whole inner ear, and those patients will sometimes have a hearing loss with their episode. Many times, and so they would have a sudden hearing loss and a vertigo spell, but it's just a one single vertigo spell. They don't have the recurrent spells like the Meniere's patients have. And then sometimes it'll have a really bad vertigo spell lasting for 24 hours or so, and then off balance afterwards, and the hearing is okay, and that would be the vestibular neuronitis problem. So when someone has, if I were to take a pencil and stick it in my ear, if I were to damage my inner ear, you kind of go through these 3 phases of recovery. The first phase of recovery is a recovery where your eyes are trying to recover. And if I took the pencil in all of a sudden and stuck it in my ear, not only would I get sick to my stomach, but I would also not be able to focus, and my eyes would be clipping along. That's what Donna was referring to, called nystagmus. And that's something, when you disturb the inner ear, the eyes just move like crazy, and you can't focus. You can't see people very well. And the first phase of recovery is the eyes recovering so that you can see. The second phase of recovery is one where someone recovers their balance. So I may not even be able to walk for several days, and then over time, my inner ear, my brain adjusts to the changes in the inner ear, and I get to where I can kind of walk and kind of get by. And it slowly gets better. Typically, that's a 2 to 3 week period of time. And then the final phase of recovery is where you remember the test she was talking about with the chair, where the chair turned from side to side? That's measuring the vestibular ocular reflex, and that's the last thing that recovers after a severe vertigo spell or after an injury to the inner ear. And that typically takes about 2 to 3 months for that to recover. And some people, the recovery is better than others, so sometimes we'll actually have someone go through some physical therapy. If their recovery is incomplete or if it's very slow in happening, there are things that can be done to intervene to help speed that process along. So labyrinthitis, vestibular neuritis are very, very common and can be very severe when they occur. One of the newer, more recently described forms of dizziness is this persistent postural perceptual dizziness, and it's one that is remember, as you may recall, Donna was describing the rocking sensation or the swaying, which lasts for months at a time, and so this is kind of a newly described, just within the last 5 to 10 years it's been described. It can be present for weeks or months, and doesn't tend to, as opposed to the labyrinthitis and the vestibular neuritis, it doesn't show that it's getting better over time. And so, and these people can be very severely affected and can be very limited in their activities and their movements. It tends to be worse with postural changes. It tends to be worse with movements or motion-rich environments. Going to the grocery store and going down the aisles can be a very impossible for some people because of this type of a problem. And it can happen after a vertigo episode. It can happen after something like traumatic, like an automobile accident. It can happen after an operation was done. It can happen after something that changes, but for whatever reason, the brain is not able to recover, is not able to respond to that. And we don't understand the cause of this. It's a fairly common form of dizziness. A lot of times the anxiety that goes with that can be a factor that makes it worse or that makes it linger, we think. So it's kind of a comorbid factor, but it doesn't go away. And one of the treatments that's been very helpful is oftentimes physical therapy, a specialty form of physical therapy called vestibular rehabilitation, but also the use of medications originally developed for one thing that are used for something else. So patients that were originally, medications that were originally developed for depression can oftentimes help this particular problem. So, and it's because it's a central nervous system problem. So, it's a common problem, and one that a lot of times, unfortunately, patients like this oftentimes go from one doctor to the next, and no one ever really helps them, and we see that just on a day-to-day basis. And one of the things that can be a difficult thing to diagnose is problems with migraine-related dizziness. 20% of people, or excuse me, 15% of the population will have a migraine-related problem. Sometimes it's headaches. We have a little handout I like to give patients. It's called More Than a Migraine. And so people think of migraine headaches, they think, well, that's a headache problem. That can't possibly affect other parts of the system. But people forget about, you can have an ocular migraine where the eyes are affected. You can have people that get migraines will tell you, gosh, I get sensitive to sound, I get sensitive to lights, I get sensitive to smells that are offensive. And so many times the distortion of the sensory system can affect the balance system. And if you carefully talk to people who are migraine patients, 40% of them will tell you at one point they've had some dizziness problems. So it's extremely common, and sometimes it affects people just very minor, just to a very minor extent. It's a minor problem, but sometimes it can be a very debilitating problem. It can be a problem that is totally disabling for that patient. And this, again, like the prior discussion, can last for weeks or months, or even I've seen it last years. So it can be a very, very severe problem. One of the things about migraines is that migraines typically have triggers. And one of the things that we try to coach our patients about is figuring out what those triggers are. Sometimes the triggers may be certain foods, certain cheeses, or certain wines, or certain things that they would eat. Sometimes it can be a change in weather, a change in barometric pressure. Sometimes it can be a hormonal type of thing. Women especially going through change of life or other things can be affected by that. Sometimes even young girls, we'll see young girls as they mature going through that. Sometimes stressful situations, loss of a loved one, going through a divorce, or things of that nature can do it. So different triggers, and kind of trying to discover what those different triggers are can be part of the discussion that we have. I mentioned about the sensory distortion, the light sensitivity, the sound sensitivity, the smell sensitivity, the motion sensitivity that can go with that, and that's very, very, very common. So it is definitely more than a headache. The good news is that there are treatments, and the treatments in some ways are similar to what's used for migraine headaches, but in some ways they're different. So we have two different types of medicines with migraines. There are preventative medicines, and some of these are listed here. Medicines, we use a lot of Topamax, but there are other calcium channel blockers, certain tricyclic antidepressants that are sometimes used, or what are called beta blockers can be used. And then there are also medicines that are used to block or abort a vertigo spell, or to abort a headache, and they're the same medicines. The Imitrex and the Relpax are two of the more common ones that are available. So it's something that we're understanding more as time goes by, and it probably has to do as much as anything with the way the nerve cells work. Migraines are something that is an inherited tendency. So I know my parents both had migraine headaches, and I've had a migraine headache or two in my lifetime, and my children have had it. So I've unfortunately passed it along to my children, but it's something that tends to run in families, and does have a genetic background. One of the more common, we've got some seniors in the audience here, and one of the more common related issues that we see is age-related balance issues. And there is, unfortunately, once you hit age of 55, and I'm past that age myself, there starts to be a loss of function, not only within the inner ear, but there's vision loss that takes place, and there's loss of feeling the ground underneath you. And the brain changes. It doesn't, sometimes you might, if you're over 55, I can't quite remember things quite as well. So the brain is working a little bit differently as well. So your system changes, and those changes can result in changes in balance. Now, oftentimes they're very minor, but as the years go by, as you get into your 60s and 70s and 80s, it can become more of an issue. And some of the statistics that are out there are somewhat frightening, because 1 in 3 adults over 65 will fall every year, but only about half the time do they go to the doctor's office. So it can be serious. We had someone recently that unfortunately fell, hit their head, went to the doctor's office, and turned out sometimes there can be serious things in the brain, even bleeding in the brain that can happen. So you want to, it is worthwhile if there's a fall to be seen. And then hip fractures. Many of you may have known a family member or a friend that's fallen and broken their hip, and that can be a very, very serious problem. Thankfully, when it's managed properly, it can be oftentimes people can be put back together, but there is an incidence as high as 67% in some studies where people who sustained a hip fracture didn't come home from the hospital afterwards. There's various grading systems based on the falling, whether you felt like you were going to fall and fell, or whether you just felt like you were going to fall and didn't fall. And so the most likely thing if someone has fallen once, they're likely to fall again. That's the most predictive measure of fall likelihood, is if you had a prior fall. Balance is a use it or lose it type of thing. So people oftentimes, as they age, will become less active. One of the proactive things that you can do is to stay physically active. Walking is a great exercise, but going to the YMCA and things of that nature are also a good idea as well. Staying active is important. And then sometimes we will have our patients, especially if they have had a history of falling, we'll have our patients go through physical therapy to strengthen their balance system. It's a use it or lose it system. And then also good general health types of things, maintaining a healthy diet, keeping the blood pressure under good control, keeping the weight under control. Those are all factors that can lead to a better balance especially in the senior years. And then finally, we kind of started off talking about acoustic neuromas, but acoustic neuromas are one of the things that is near and dear to my heart, because it's kind of the disease that kind of led to the specialty that I practice, which is called neuro-otology. And so we're constantly looking for acoustic neuromas. So we look for them with the hearing testing, we look for them with the imaging studies, and so we have a very high index of suspicion. We're constantly looking for them because they are a serious thing. And if they happen, they can even be a life-threatening thing if they get very large. So thankfully, by having a high index of suspicion, we can catch these before they get too large and before they cause problems. And most of the time now, with acoustic neuromas, most of the time we just watch and see if they're going to grow. And a lot of times the tumor will grow, and it'll stop growing at one point, and we don't have to do anything other than watch it with serial imaging studies. So sometimes they do have to be removed, especially if they're large, especially if they're showing signs of growing, and sometimes we can even use radiation to treat them. But and so when we ask someone to get an MRI scan, oftentimes this is what we're looking for. There are other things as well, but looking for acoustic neuromas is an important part of what we're doing. So finally, I want to talk about a kind of a new disorder, and we were talking about the crystals and how that can be affected. A new disorder that's been described by Dr. Lloyd Minor at Johns Hopkins is this absence of the covering on one of the balance canals. Now, I wouldn't expect any of you to see this, but if you look really closely right here, you'll see a little gray kind of half circle, and then that gray half circle opens up to this area here, which is the brain. And that balance canal is not covered with bone. So when the balance canal is not covered with bone, it changes the way the inner ear works. It's called a third window effect, and it means that there is pressure that can get into the inner ear from other ways. So the pressure can get into the inner ear from the brain here. So when these patients will exert themselves, the pressure from the brain builds, and the pressure pushes on the balance canal, and they get dizziness. Sometimes they can get dizziness from certain sounds. So they would get dizzy if there's, I had someone the other day tell me, gosh, I get dizzy when I go to Home Depot and there's that backing up sound that the machines make as they're loading and unloading the shelves there. And he would just, every time that beep would happen, he would just move. Sometimes it can happen, very strange phenomena, but it happens. Patients with this disorder will describe they can hear their eyes as they move. Strange thing, but it really, they will tell you, they hear internal sounds that would not normally be heard. I don't know if any of you all are sports fans, but Sean McDonough, who's the announcer on, I think he's been on ESPN, he's a Boston sports guy, has had this problem, has actually been very open in the media about this and actually underwent surgery to repair it. So it can be very disabling, it can be very limiting for patients. The symptoms can be very, very different. Some people will just have they'll hear their own voice. They'll get what's called autophony, and that can be their major symptoms. Sometimes they'll get these pressure-related symptoms. Many times we can treat it medically and get it under control with medications, but when it is very limiting to patients, when it is affecting their quality of life, there are surgical interventions that are available. Most commonly, to block off this balance canal so that the pressures of the brain and other pressures aren't exerted in an abnormal fashion. So I know we've covered a lot of territory, probably more than you'd ever want to know about your inner ear and more than you'd ever want to know about what can go wrong with it. We'd like to open up to a few questions for the audience as a whole. Do we have a microphone that we can pass around? Yeah, I think at the back there's a microphone, and so if any of you have questions, we'll try to take a few questions as a group, and then we can take some additional questions individually afterwards if we don't have enough time to answer all your questions. Anybody going to be brave and ask the first question? Yeah, I think I...
Thank you. For years I've had problems off and on, but I have carried meclizine in my purse for years because as soon as I feel something, if I get that under my tongue or in my system, it calms everything down. Now, my concern is someone who doesn't like to take medications. What over the course of so sometimes when a bout hits me, I might do a meclizine every other day for about 6 days, and then I go off of it for 3, 4, 6 months. Now I've had some really bad problems. But my question is, what are medications like meclizine over the course of using them regularly to treat dizziness? Do they have side effects or breakdowns that they're causing? I believe it's an antihistamine, right?
Right, yeah.
And antihistamine's dry, so we know it's drying the inner ear, but it works really fast. But I'm concerned about side effects for using this regularly.
Sure. So the question is about meclizine. So meclizine is a medicine that is an antihistamine, but the effect is it's a vestibular suppressant. So it suppresses some of the abnormal balance signals that people can get. It works well. One of the downsides to meclizine is it can cause sedation effects. So it can make a person sleepy. So some people have a hard time taking it because they're going to fall asleep, and they can't do that at work or other places, driving a car, for instance. So, but meclizine is very safe. It's one of the safest medication. I would have no concern taking it even on a daily basis because it does have such a high safety record, and you know, if as long as the sedation effects are not too severe, I don't think there'd be any problem with that at all. Donna, you want to add anything to that?
No, I guess what I would add is please come see us. Our hope would be that you don't have to take it. We can sort out what's going on and sort it out enough that you're done with meclizine. So there's hope. Okay.
Anybody else? Yes, please.
Yes. Is there any validity to a simple solution like putting your eye up for a few seconds and then down, left and right, if you get an acute episode?
Yeah, what you're describing are what are called Cooksey-Cawthorn exercises, which is a particular, and sometimes that can help. Sometimes it can help if you are able to kind of, like I mentioned, the involuntary eye movements that's hard to focus. Sometimes if you look one direction, you can help to reduce that slightly. It doesn't change what's happening on the inside of your head, but sometimes it can help some with the symptoms. So if I'm having these involuntary eye movements and if I can focus on something, sometimes that will slow it down a little bit and I'll feel slightly better. Does that make sense? Yes. Sure. I'm going to ask Donna to handle that question because that's something we see frequently.
Yes. So when you're on the cruise or on the airplane, your central nervous system sort of resets to that, and there is a compensation process when you get on land. I know I've personally felt it. It's very interesting where you're standing on solid ground and suddenly feel like the boat just rocked. That is a situation that should be very temporarily over a day or 2 days. Unfortunately, there are conditions where that will persist long term, and that's something where patients will come and see us called mal de débarquement, where you, roughly translated from French, means getting off the boat badly, and you haven't compensated, and we can also test and help for that. But it's normal for that to happen for short term. That's okay.
We have a question over here.
Yes, please.
Hi. Whoop. Hi, good afternoon. Thank you for your presentation. It was very clear and helpful. I appreciate that. I experience dizziness and almost loss of balance frequently when I rise from a stoop position as working in the lawn or sitting for a period of time or lying down for a period of time and rise rapidly. I've associated it with lower blood pressure, but I'm not sure if there's anything here that you'd like to comment about that might have caused that.
Yeah, one of the things that's worthwhile to do is to see your primary care doctor, because sometimes there is a problem. When you change positions, your blood pressure changes. If I'm laying flat, my heart doesn't have to work as hard as when I'm vertical or upright, and the blood pressure will correspondingly go up. So one of the things that your primary care doctor can check is he can check your blood pressure in those different positions and see if it's going up accordingly. So it is worthwhile to get that checked. There are also, that being said, there also are conditions both in the inner ear and in the brain that can cause symptoms when you change position like that. Sometimes it's related to the brain not having adjusted to damage to the inner ear. That would be one of the potential causes. Sometimes it's related to other factors. So it is worth getting looked into. And a lot of people always say, well, gosh, when should something like this be treated? When should I go see someone for it? And a lot of it is related to how it affects your quality of life. So the more significant the quality of life impact, the more it's worthwhile to be seen, and the more important it is to be seen. But now that being said, you saw the picture with Kelley Stafford and her. Okay, sometimes the symptoms can be very minimal for an acoustic neuroma, so it is worthwhile to get symptoms checked out, especially initially even if they're minor. It's worthwhile to get them checked out. So why don't we take maybe one more question, and then we can take individual questions afterwards. So yes, I think back there with the striped shirt. Yes.
Chronic vertigo and tinnitus for about 18 months now, and it is perpetual. And your slide on persistent postular perceptual dizziness is the first time through an entire odyssey of the last 18 months of going to doctor's offices that we've heard about this. So we're very interested in learning a little bit more about that, but also I'm curious, you mentioned both some medication treatments as well as vestibular rehab, which I know he's been through.
Uh-huh.
What is the success rate of those treatments? Do you know it? Because it sounds like it's a fairly new diagnosis.
You know, I don't know if I can give you a specific number. I think I will say that most patients improve. Probably 90% of patients will improve through a combination of medication and with good physical therapy. And I will say something too. I mean, all physical therapy is not the same. So, you know, we usually encourage people to go to people that have special training in balance-related rehabilitation, which is different too. So. The devil's in the details, as the saying goes, with a lot of that. But most people can be treated with this particular condition. And it is a new condition, and unfortunately a lot of doctors and people that aren't in this field are not familiar with it.
Thank you so much.
You're welcome. My pleasure. Well, thank you guys very, very much for coming today. Appreciate your coming. If there are individual questions, we'll be glad to answer. Judy Nelson and Donna and Janelle and I will be happy to answer any questions individually. Thank you.